The problem is very common, right? When you the patient came to see with knee pain. So first, I think the age can tell you the differential diagnosis. The age, okay? If the patient very young, okay, came to see you, or the elderly patient, sometimes the differential diagnosis is different. Okay? So let's say this is the young active patient. They came to see you with knee pain. So first you need to think about, because a young active always have the knee trauma, right? Sometimes acute traumatic injury, sometimes repetitive injury. So the chief complaint, sometimes you can guess what is the problem of the patient. If the patient has the acute knee injury, like twist, very common in our country, is the football injury, okay? And nowadays, the surf skate very common, right? Surf skate. If you didn't have the protection, you need to protect the knee, right? Elbow, wrist, and the head. So the surf skate, right? So a few days ago, there's a drama in the social. There's a fracture patella. You heard about that? The patient fractured patella, and they came to private hospital. The cost is 400,000 baht. So very costly. Yeah, that's 400,000.
Wow.
So very expensive. So let's say the patient have knee injury, came to see you. So you need to ask the mechanism of injury, right? Sometimes you can guess, like the patient twist the knee. So the common sports in our country, like football, right? Badminton, also very common. Badminton, basketball, rugby for men, right? Rugby players. Running. Running is not twisting injury. So the twisting injury is very typical, like this type of sport that you need to twist the knee. If the patient twists the knee and have acute knee injury, you need to ask the mechanism. So this is a common mechanism, twist, okay? Like you play the games and twist the knee, and sudden pop. Patient can recognize that sudden pop and cannot continue to play, and knee swelling right away. So you should thinking about the intra-articular pathology, like what's that? Most common ACL. What's it? MCL, like this. So the MCL will be very tight, right? And meniscus can be torn, medial or lateral side. Another one is the kneecap. Sometimes you forget the kneecap. Sometimes you have the kneecap dislocation, okay, or patellar dislocation. So first you see the patient examination. You should compare both sides and to see the difference. If the patient have chronic injury, most of the time they will have the quadricep muscle atrophy. If you see that the patient have obvious muscle atrophy, that should be some significant pathology in the joint. Okay? I think most of the chronic knee pain that will have this muscle atrophy. If you measure the size or the circumference of the knee, most of the time we measure 10 centimeters from the upper pole patella and measure the circumference, comparing both sides. This is much smaller. It's much smaller. That means the patient has significant pathology. Your knees weak or not? Same, huh?
It's the same.
It's same. Okay, good. So, so you start. I told you already, right? How to do the knee examination. You start from inspection. Do see the alignment, leg discrepancy, any deformities, right? If the knee is swollen, you cannot see the dimple. See that? This is the dimple. That means the knee has no effusion. If the knee is very round, there's no dimple, or you cannot see the skin crease, that means the knee have some effusion. So if the acute effusion, that is the blood. You know, that should be acute bleeding. Okay, and a lot of bleeding is in some Meniscus, you have little breathing. So if you have meniscus tear, most time you have little breathing. Sometimes you cannot recognize the effusion. It's different from ACL, right? ACL, you have a lot of breathing from the ACL. For the PCL, you also have little breathing because the structure is in the back, you know. Sometimes the breathing will be here in the extra compartment. You didn't see any effusion or allotment will be negative. Okay. So first, you need to remember the surface landmark. Can I draw?
Yeah.
Yeah. So this is the patella, right? The patella, this is the kneecap. See? So when you bend the knee to 90 degrees and you feel the lower pole patella, right? Is this the medial lateral soft spot? Okay. Okay. So this is the joint line. Okay. Then you feel the space here. Okay. You can feel the space. So this draw this. This is the medial joint line, and you also can feel the soft spot. This is femoral condyle, right? You can feel this. This is a soft spot to the back. So this is another way to go into the joint, not only the front, okay, but it's not so common because this space actually you need to have some fluid in the joint. You can aspirate. Yeah, this is the posterior soft spot. Okay. This is a tibia. Same on the lateral side. Okay. So I think surface landmark is very important. You need to know. This is tibial tubercle. Okay. I make it TT. Yeah? Tibial tubercle. And you can feel this tubercle. Where's that money? What is this tubercle? G. This is Gertie tubercle. Okay. Tibial tubercle, Gertie tubercle. And what is this tubercle? Huh? This is a fibular head. Okay. It's fibular head. And if you drag, and you can feel that this is the lateral epicondyle. Okay, let it dry first. I will let you feel. And you feel this, you can feel the LCL. Okay, the way to feel LCL, you need to do like figure 4. Then I can feel the lateral collateral ligament. If you didn't do this figure 4, you cannot feel the LCL. Okay, so this LCL, and this is the peroneal nerve is here. It's just behind the fibula. So sometimes if you make a T-nail side here, you can feel the tingling sensation. Like in fracture hip, Patrick fracture, the patient lie in axial rotation, they have foot drop because the nerve is just behind the fibula. So that is the structures. So from here you can feel this tendon coming from the foot. So that IT band. This is IT band. Okay, this is LCL. And next on the medial side, there will be 3 tendons attached here. What's it that? This is pes and serinus. Okay, pes and serinus. Yeah. Okay, here. And then on the medial side, here you can feel the medial epicondyle. Medial epicondyle. And then what structures? It is over or not or under the pes. You think it's over or not under the pes? Under the pes, very good. So between this is tendon, right? This is ligament. Because between tendon and tendon or tendon and ligament, you should have bursa between. So we call this area pes and serinus bursa. Okay, and sometimes have bursitis. That's why that pain, because this is the bursa between the tendon, the pes semitendinosus, scapulis, and sartorius, right? And this is MCL. Okay. So these are the structures of the knee. Okay. So if you can remember this, you can diagnose most of the patients that have came to see you with knee pain. Okay. Okay, now I let everyone palpate. Okay. You feel epicondyle, you feel fibula, right? And you can feel this LCL. Okay, everyone feel this. Put your finger like yeah. Can you feel? That's it. LCL. It's called light. Called light. Called light structure. Can you feel? Choosing one you want to feel?
Yes, of course.
Yeah. Called light structure.
Oh, okay.
Yeah.
Yeah.
Yeah. It's called light structure. Yeah. Very thick, right? Yeah. But if you didn't do this figure 4, you cannot feel because you need tension. Okay.
So we are stretching the lateral.
Yeah, right. Called light structure, right? Lawrence, you want to feel?
Okay.
Can you? Lawrence? Called light structure.
Okay.
Can you
Oh,
feel?
very prominent.
Yeah, very prominent, right? This is the LCL. Okay? So if you have this and you have intact LCL, you can feel that the tension is good. And if the patient have torn LCL, you can feel that the patient had pain at this LCL. So that is the superficial structures, right? These structures is bicep femoris. The perineum is just behind, okay? And there's an interval between the bicep femoris and the iliotibial band. So this is the space that we go when we do surgery. We always go through this space interval between bicep and the iliotibial band. Okay? And also there is a soft spot here. You can feel this is a lateral soft spot. It's a lateral soft spot is between the LCL and the bicep femoris. Okay? So these structures, iliotibial band. No.
Which kind of sport?
Which kind of sport have the problem of this iliotibial band? Sometimes they came to see you with the lateral joint line pain, lateral knee pain, marathon runner. We call this when you run, right? The iliotibial band keep moving, okay, on the lateral epicondyle. Okay, this is lateral epicondyle. Just keep moving. So the patient would have pain or bursitis underneath the iliotibial band. We call IT band friction syndrome. Friction syndrome, very common in marathon runner. Okay? IT band friction syndrome. If you see the patient, the runners came to see you with lateral knee pain, thinking about this, okay? The IT band friction syndrome. Okay? And sometimes the patient may complain pain at the gouty tubercle also. Okay? Good. And for this LCL, if the patient have knee injury like this, okay, Wallace injury, sometimes you may torn, because in this position, the tension of the ligament very high, right, very tight. Okay, this is for the lateral side knee pain. Okay. So attached to the gouty tubercle, right?
So this is the gouty tubercle.
Yeah, that is gouty tubercle. So this is a gouty tubercle, this one, G, right? Tubercle, and that is the lateral, there's a bicep femoris, right? That's the femoris. That is the fibula head, right? Okay. I think they try to present this LCL, right? LCL is this one. This is fibula. This one. This is anterolateral ligament. Actually, this is just the new idea. That's one ligament attached from this to the Gertie tubercle. This ALL, right? Anterolateral ligament. That we are thinking about. You remember the second fracture yesterday, right? Yeah, the second fracture is the avulsion of this ALL. Okay, and nowadays they propose that when the patient have really loose knee, after you do ACL reconstruction, you should reconstruction this ligament also to improve the knee stability. But this is the new, just a very new idea, you know. But they propose that why we have second fracture because this structure was torn when you have ACL injury. Okay, anterolateral ligament, ALL.
Where is
LCL is here, this one.
They call it fibula.
Yeah. You can call it fibula collateral ligament, or you can call it LCL. FCL and LCL is the same one.
The MCL would be tibial collateral ligament.
Yeah, tibial collateral ligament, right? So that's a structure you need to know. Okay. Actually, that's another ligament. Actually, it's the muscles. It's the muscles, but it's act like ligament. This one is a popliteus tendon. Okay, it's come like this ligament, right? It's attached from this to this. Okay, maybe this too complicated for you. So the lateral structure will be popliteus and the LCL. Okay, these two structures. Okay, this one and this one. Okay, actually this one is the arcuate popliteal ligament. Yeah, it's just behind. You don't need to remember, it's too complicated. Okay, these two structures, this one and this one. Okay, good. That is the lateral structures. Now coming to the medial side. Okay, for the medial side you have this. Oh, sorry. For the medial side, you have this sarcasm, right? Sartorius, gracilis, and semitendinosus, like this. Okay. Yeah. Sartorius, gracilis, semitendinosus, right? So that's three ligaments. So this is the hamstring. So bicep femoris and also the sarcasm is the hamstring. So the function of hamstring is to bend, is doing the knee flexion. Yeah. You have medial side, lateral side. But the medial side you have many, right? You have three. So this is a spare part. I always take this out, the semitendinosus or gracilis. Let's say you have torn ligament, you can take this to be the spare part for you to do ACL, PCL, to do the ligament reconstruction. Sometimes we use it for shoulder. Yeah. So in case you have enough spare parts. Some patients have 2-3 times injury. So if you revise the patient for many times, you have no more left. So finally, you need to take from the dead people. We call allograft. Okay. So this one we call autograft. Autograft just means you take from the patient. Okay. So this structure is a knee flexion, and also actually this is the secondary stabilizer for ACL. Help ACL to stabilize the knee. Okay, because the function of the hamstring is to bend the knee. Same like ACL also preventing anti-translation, right? This one also preventing anti-translation. That's why when you do the Lachman test, right, or drawer test, if the patient have hamstring tightness, you cannot test. Remember? Yeah, last time I told you if you didn't do this way, yeah, rolling and talk to the patient feel relaxed, then you can test the knee. Okay, what's your question, I think?
So like this three is called kiss and service.
Okay. Okay. So now you can see these structures. Right. Can you take this out? Opposite side.
You want to hide it?
Cannot, right?
Maybe you use like this.
Okay. Okay.
อาจารย์อยากหมุน
ไม่งั้น
You want to
ใช้เข่านี้ได้ไหม
No, it's okay. Yeah. So this is a medial collateral ligament. So you see that the medial collateral ligament is very long. You see the attachment. It's nearly 6 centimeters from the joint line. Okay, so that's why they need to divide into superficial part. This one that you see is a long one. It's like this, very long. This is a superficial part, and underneath is a deep part, right? Deep MCL, superficial MCL. So this is a primary stabilizer for the medial side injury. Okay? But the structure of the medial side and lateral side is totally different. The medial side is like a patch. Yeah, so it's flat. Yeah, this is cord-like. Okay, it's different. You can feel it's like cord-like, right? Yes, but this side is very flat. So, yeah, to reconstruct the medial side is not easy because the structure is very unique. Because most of your spare part is like tube, right? Yeah, it's like tubular when you do reconstruction, ACL or something. It's like you make a tube, right? But the medial side is very flat, so not easy to replace it. Okay?
So if we harvest the cylindrical structure, then can we flatten or maybe like fan?
You can make it. You can tap it. I mean, when you put it down, right? You need to spread it. You need to spread it like you put something push on the top so the tendon spread. Yeah, like a staple. If you put the bone stable and then we spread it. That's also possible. Okay. Doing the special examination. Okay. So for the medial side, very common. The patient came to see you with the medial joint line pain, right? So if the patient have joint line pain, maybe it can from the meniscus or from the MCL or mid-substance MCL, right? Okay. So this is the two structures that may present with the patient may present with knee pain, meniscus or MCL, or finally the cartilage at the medial joint. If the patient have arthritic change, also the patient will have joint line pain. Okay, medial joint line pain. Okay. So next is the anterior knee pain, right? Anterior knee pain actually is very common, especially the medial lateral side. Most of the time you have some accident or injury, right? But for the anterior knee pain, most of the cases is not from accident. Okay, it's from the anterior knee. You can see that the patient have kneecap, right? This is patellar tendon, and this is knee patellar tendon, tibial tubercle. Okay? So bend your knee like this. Okay? So in the middle, in the central, you have pain. So if the patient had pain here at the lower pole, the patella, okay? So what you're thinking about, which type of sports? Lower pole. Jumpers. We call jumpers knee. Okay. So I have many natural athletes, the jumpers. They always have this problem. The patient has pain at the lower pole or the patella. Sometimes they have this spur formation. Sometimes they have the partial tear of the patellar tendon. Because the patellar tendon, if you're the jumpers, you keep using, right? So there will be some degenerative change or some tear of the lower pole of the patella. Upper pole patella, sorry. Upper patellar tendon and lower pole of the patellar bone, right? The junction. So the simple test is you put your finger on the bone so that we have pain. It's like tennis elbow, like golfer elbow. This is insertional tendinitis, or you can say tendon of entisopathy. Okay, so this is the pain at the lower pole. Okay, what is the pain here? Tibial tubercle pain. Or Scooch-Schlatter, right? But this is unique in young, the teenagers active in sports, right? They have a pain and prominence. The problem is this patient cannot kneel on the floor because it's prominent. It's painful when the patient try to kneel on the floor, okay, or squat on the floor, okay? Yeah. Ajahn Thanapong also have this, if you can remember Ajahn Thanapong. He has really big tibial tubercle. Maybe I show you later. Yeah, yeah, he's active in sport. He's from OSK. Same we call apophysis. You have epiphysis, right? Epiphysis, like distal femur, proximal tibia. But this area we call apophysis. Apophysis. So yesterday you remember the one that I tested you, right? You feel like there's a gap between the bone. But actually that is the apophysis. This is traction epiphysis. Okay? So that's why it's keep growing, because if you active in sports, so the patella keep traction. So this bone will be bigger. Okay? So that is Osgood-Schlatter. Okay? So the next that is very common is the anterior knee pain, especially in women. Right? If the patient came to see you without any accident, they came to see you like the patient this Monday, the dentist, remember? Yeah, the dentist. She had anterior knee pain, right? No accident, just anterior knee pain. So anterior knee pain, sometimes you need to differentiate. Two common disease is the patella itself, patella and patellar articulation. Okay. So what you have to look for is to look at the patella, is that stable or not? Okay. By doing this way. Okay. Yeah, this is gliding. Okay. To see the stability. Okay. You should move medial, lateral. Both sides should be the same. Okay. It's different from the patient yesterday I showed you in the video, right? So I push it like this, the patient feel it's going out and try to stop me, right? That is a patellar apprehension test. Okay. So this is patellar gliding. Okay. And another way is to do this way. You try to push your kneecap over the trochlea. Okay, to feel the surface underneath. Okay. If your kneecap is not smooth or trochlea is not smooth, you can feel that it's not. You can feel the crepitation.
This is the gliding to like the patellar gliding.
No, this is gliding. So this one I try to put the pressure on it. So this is the grinding, gliding, right? Okay, so it's smooth. Yeah, you can feel. Everyone, you can feel. This is, yeah. Move medial lateral.
It won't be dislocated, right?
No, it's there.
Very smooth.
So you move this way. Your purpose is to see the stability, not the surface. Understand? This way, and this way. Okay. This way you move it on the track, right? But this way you move it medial lateral to see the balance of patella, because the patella is structure is the sesamoid bone, right? So this need to balance, right, on the track. So if it's not balanced, when you push, it can dislocate easily, right? So very unique structure is the patella. Okay. So that is the patella. Yeah, this is
So this one is check the smoothness.
check the, yeah, right.
But this one is check the.
Right. Actually, you can do many ways. You can do this way also and let the patient move. You push it like that and move, okay, to feel the surface underneath. Okay. Another one that most of the surgeons don't think about that is the soft tissue impingement. Okay. It's always on the medial side. Okay. So you bend your knee like this, okay, and you feel this soft spot. Imagine this is a femoral condyle. This is a soft spot. Okay, you can feel femoral condyle. If the patient have something impinge, two things that's always impinge is the fat tissue behind the patella. We call the Hoffa fat pad. Okay, it's just behind the patella. You imagine if this fat pad is very thick, it can impinge when you try to move your knee, right, bend or extend. So the patient would feel pain when you try to squat or deep bending for a long time. Okay. So this patient, the typical history, remember the dentist? Yeah, that part he present me in the wrong way. He said when the patient walk, I said that's wrong because walking you didn't have this problem. The patient would have problem when the patient getting up downstairs, squat, or sitting in bending for a long time, or sitting in a very close place. That's what they call movie sign, right? Have you heard about that? No, movie sign. If you sit in the movie for a long time, something, when you try to
like this.
yeah, something like that. Okay? For a long time. When you try to extend your knee, that would have pain. Okay. So the size, the positive side is that you put your finger at the soft spot, okay, and try to move your knee. Okay. Sometimes you can feel the click, but the click is I think many of you have click, but if you have no pain, that is not a pathologic spur, and that is not a pathologic prega. Okay. There's a soft tissue we call the Hoffa fat pad, and also there's a soft tissue that from the capsule you call the medial prega. You have pictures, show them the medial prega. Okay. So the prega will be between these two bones.
So we palpate here.
Yeah, you palpate here. So this is the medial capsule, right? You imagine this tibia. Sorry.
ค่ะได้
So between the medial and lateral is coming this way. Understand? It's go between the patella and the femur. Understand? When we move the knee, bending flexion extension, this will be in the middle. Okay? That's impinge, and you can feel the click on the medial soft spot. So this is the prega. Okay. How far fat pad is here? How far fat pad is the structures? Because in your knee joint, this is ACL, PCL, right? Medial side. This is ACL, PCL. Okay. So the soft tissue, this is meniscus. Right? The soft tissue in front of this, sometimes very thick, you know. I don't mean you. Okay, this sometimes very thick, and when you bend the knee, this tissue obstruct. Yeah. So this one.
So it's like obesity or risk of the
Yeah, this one. You see that is impinged. That is femoral condyle. Okay, that is the medial capsule, right? So these structures impinge on the femoral condyle. Patella, this is femur. Okay, between. It's in the middle. Okay? That's why that produce pain. Okay? See
Is
that?
it circumferential?
No, it's like semicircle, like C shape.
So the same
Yeah.
as the meniscus.
Yeah, right. But it's attached on the supromedial part. So from here, it's attached like this. You see, it's like C shape.
Is it like a part of the meniscus?
No. That is it's a synovial fold. That is a medial capsule.
Or it's a synovial?
Yeah. This is the medial capsule, right? Femur, patella, and that is anterior. So it's attached like this. So this is after I remove it. See? You see it's clear now. Yeah. Before that, it's impinged. It's in between the femur and tibia. Okay.
And then prega, what is the risk factor of having the prega?
It's congenital. Actually, everyone have this prega. Sometimes very thin, sometimes very thick. Yeah.
It caused the click.
Cause a click. Yeah. Right in, right? Yeah. Now cleaning, remove the bubbles. So this one, she has the very thick prega. So we change the scope.
This is the dentist.
No, this is another one. You see that? It's so thick, right? So thick. So this patient actually he was the operate before, but he's not getting better. So I revise him again. Yeah, this very thick, right?
It can regrow.
No, I think the first doctor he didn't cut it. Yeah, he just address the yeah. So this is really thick. So we need to revise. Yeah, right. You can see that this plica is very thick, and also you see.
But in normal people, we don't need plica. Like, does it have any function?
No. You see that this very thick. He had both sides, so I did this for him. Okay, understand now, right? It's coming from the middle capsule. Now it's clean, and this patient very happy. Okay. Knee pain is a knee instability. So the patient may came to see you, same like ACL. They feel like knee unstable and giving way. That means when the patient beat, sometimes they twist the knee or zigzag, change the positions very fast. They fell down on the floor. We call this giving way. Yeah, it's like knee unstable. So the way to check is to do patella apprehension test or gliding. Okay? Okay. So that is the anterior knee, medial side, lateral side. Okay.
The medial plica is considered anterior knee pain.
Yeah, anterior knee pain. Anteromedial.
Lateral plica.
No, there's no lateral plica.
Only medial.
Yeah, only medial. Only medial. Actually, the plica, when we are the embryo, this plica is like a septum that separate the knee into many rooms. You know. Yeah, and finally it disappear. So this will have this medial side. Actually, there's another one on the top. It's like a door. Yeah, separate our superior compartment into two rooms. Okay, and actually there's another room in the middle, separate medial and lateral. Okay, so finally it is a ligamentum mucosum. It is a structure in front of the knee. Okay. Okay, good. So this is the common knee problem, right? And then you can check the stability of the knee. Okay. Have you tried the Lackman, drawer, McMurray, and pivot shift? Okay. Show me again. I did.
Hard.
Yeah. Show me the way you do Lackman test, Walker's, Wallace strength test. So use first, I show you first. So you start with the knee extension first. Remember 0, 30, 90, okay? Because the concept is that you test the knee with non-invasive first. And the last procedure should be invasive. That or some procedure that produce pain. Yeah? Because if you do the invasive procedure, the patient will not cooperate you anymore. Okay? So start with the knee extension, okay? Valgus, okay? Like this, and Wallace, like this. Okay? But actually, you can modify. I prefer to do this way. If the patient is not so big, I prefer to put my finger, okay? Control the knee, medial lateral side, okay? And then I check valgus. I can feel that the joint is open or not because my finger is on the joint line, okay? And then I do Wallace. I can feel the stability of the knee joint, okay? But for you, if you're not keen, you can do this way. This is valgus, okay? It's like 3-point bending. You push like this, okay? And if the MCL is torn, the joint will be open. So you start with valgus, Wallace at 0, right? And then 30 degree. The concept is that you need to stabilize and don't move the proximal part. Otherwise, you cannot recognize which part is moving. Okay? You need to stabilize. This should be very stable, okay? At 0 degree, like this. And the trick is that you put the patient on the edge of the table or the bed, right? And drop it down this way, okay? And test, see, stable. The medial side, same, right? Put the hand like this, push, okay? Medial side, 0 degree, okay? And then 30 degree. So that is the Wallace stress. Okay, Wallace sometimes you can feel a little bit. This is normal. Okay, you can feel a little bit. Or I do this way. Okay, this is 0 degree. Okay, Wallace very stable. When you bend the knee a little bit, okay, you can feel that. You can move the knee a little bit. Okay, so this is Walker's and Wallace stress test. Okay, also the Lachman test. Okay, you need to relax the hamstring, both sides, medial lateral, okay, and then you just lift up this way. The patient should not help you, right? And this should not float. If you do this way, it's wrong. Okay, so just lift up this way, okay, and then yeah, should touch the table. So knee is very stable.
Would you lift up the tibia or would you lift up the?
Yeah, you hold the tibia like this, and you push the femur down. Okay, we grab the tibia and lift it up this way.
So you move both of the hands.
Yeah, we stabilize this and actually this hand. Yeah, but this hand also press it down. Counter action. Okay. Okay.
So I actually there was one patient that was very big. He was like 100 kilograms. So how would you recommend to do it? If the patient
Sometimes
is so
the Lachman test drawer not possible, but you are sure to be positive. When you want to test your friend,
yes.
which one?
Which one? What?
Or you want to check my fellow?
I think it's okay.
Oh, the last one, the better list.
เช็คขาเราทีหลังเลยนะเราใส่บ็อกซ์ด้วย ใช่ขึ้นมาอย่างนี้แล้วก็ดันอินทั้งเราเบรกแล้วก็
That's right. Zero. คือมันไม่มีหรอกหนู It's not positive because the knee is very stable. Feel the soft spot first. Yeah, this is the middle lateral soft spot. Okay.
And the posterior soft spot is.
Posterior soft spot is here.
Okay.
You can feel here,
Yeah.
just behind the femur condyle. Okay. So if the patient has a lot of effusion, this is another way to put the needle in. Right here, you can feel posterior soft spot. Because sometimes the patient have the knee flexion contracture, and it's not easy to aspirate the knee. But because you aspirate the knee, you need to extend the knee joint. But if you have flexion contracture, this is another way to aspirate. You put it here. You can feel. Yeah, there's posterior soft spot. Can you feel? Yeah, it's posterior soft spot. Just behind the femur.
So do the posterior drawer test first, and then anterior. มาทั้งตัว Okay.
Very good.
Okay. After that, then McMurray. เมื่อกี้ทำ McMurray ใช่ไหม
Medium side. This the joint space.
Like this.
So this knee you go this way.
This way.
You feel the
Medial
joint. You feel the joint first.
Okay.
here
Yeah.
joint. Yeah.
And then here.
Yeah, like that. Okay. Very good. Your hand. No.
Like this.
No. Right here.
Like this.
Yes. Very good. Okay. Bend the knee, and then rotations. Rotation.
Like this. Or like just like this. Step man.
That's good.
Okay. And then the other side.
The other side.
Like this.
Yes. Here.
So
You can.
the
You can. You can here. You should yourself should be here.
Oh. Outside the country. Like this.
That is the natural joint space. Okay. You feel the joint space. You can use the index. I use index.
Like this.
Yes, it's easier, right?
Okay.
The heel on the heel. Right. Okay. Rotations. This. That's right. That's right. Here. Rotation. Walkers. That's good. That is very good. Walkers and rotation. Okay, that's good.
And
Perfect.
then to what shift? Can you demonstrate for one?
Pivot shift. You're starting with the full extension, right? So hold the patient leg like this. Okay? Like mèo, she said. Okay? Like this. And then this is walkers, right? You need to do internal rotation. Okay? And you stabilize the proximal tibia like this. Okay? I prefer to go this way. Slowly. Okay? This way. Very gentle. Okay? This way. You stand like this, it should be stable when you move. Okay?
So first,
Mèo first. Mèo. Okay?
like
Very good. Slowly. Too fast.
Too fast?
Extension, because it will be positive at about 20 degrees. So you need to go very fast. Okay, walkers, extension, and then slowly bend. Yes, like this. Okay. Oh, very slow. That's nice. Okay, the vagus is like this, very big. And one day the patient bent the knee, this big vagus is ruptured. So it's ruptured down to the calf. Patient came with compartment syndrome. Same like compartment syndrome. It's very tense. Yeah, very tense. That patient is rheumatoid arthritis. Yeah. So very big vagus cyst. You read my articles. I published the techniques of vagus cyst surgery. You can see. The concept of vagus cyst is that it's always have intra-articular pathology like meniscus or cartilage problem. You need to address those problems. You remove all the unstable cartilage.